So hi everyone. I am very happy to be here today for another pulmonary and critical care subspecialty VMR. I'm looking forward to this discussion. We always learn so much when we are discussing pulmonary and critical care. So my name is Marcela. I am a doctor from Brazil applying to internal medicine this year. And we have very special guests here today. So I'm going to start some introductions. We have first Dr. Margaret Hayes. She's an assistant professor of medicine at Harvard Medical School. She's the director of the Medical Intensive Care Unit at the Beth Israel Deaconess Medical Center and the incoming chair of the Critical Care Executive Committee at BIDMC. She obtained her medical degree from Tufts University School of Medicine and then completed internal medicine and pulmonary critical care training at Johns Hopkins University in Baltimore. She also served as chief resident for 1 year at Johns Hopkins. During that year, she realized her passion for medical education and since then has taught in numerous CMS courses. She also directs 2 highly rated Harvard Medical School CME courses. She's an active member of the American Thoracic Society, where she serves as vice chair of Education Committee, chair of the core curriculum, and chair of the subcommittee on education and critical care, and for the Critical Care Assemblies Programming Committee. Dr. Hayes enjoys teaching learners of all levels and has won numerous local and national educational awards. Dr. Hayes has advanced training in medical education research and is passionate about critical thinking, adult learning theory, and high-stakes communication specifically around end of life in the intensive care unit. She has numerous publications on teaching communication skills as well as the importance of critical thinking in medicine. She's also interested in international medical as the director of external education at the Carl Shapiro Institute for Education and Research and has traveled extensively teaching medical education. So welcome, Dr. Hayes, and we'd love to know what do you like to do outside of medicine, and especially why did you choose pulmonary and critical care?
Awesome. Thank you so much for having me. I'm honored to be here. Outside of medicine, I have a 19-year-old Chihuahua mix who I like to hang out with and take him for walks that have become shorter and shorter as he gets older. And I'm a huge Boston Celtics fan, if anyone out there is a Boston Celtics fan too. I chose internal medicine and then critical care because I think critical care is actually internal medicine on steroids. You have to know every aspect of internal medicine, but quickly you have to learn it, and you have to learn it to a heightened degree. So that's something I really love. I also love the relationships in the unit, not only with our patients and their families, but also with everyone we work with. It's truly a team sport, working really closely with nurses and respiratory therapists and physical therapists and pharmacists. So those are the 2 main reasons that I chose it.
Oh, that's amazing. Thank you so much. And I love that internal medicine on steroids. So we also have, she'll be presenting the case to us, Dr. Ali Trainor. She's a 3rd-year pulmonary and critical care fellow at the Harvard Combined Program at NGH and BIDMC. She was also a chief resident at BIDMC and is pursuing a career in medical education. Her research interests include great burnout and the effect that the structure of medical training has on these. In her time outside of work, she's a marathon runner and a new mom. So Dr. Trainor, we'd love to hear from you a little bit more about what you like to do outside of medicine, and also why do you choose pulmonary and critical care?
Thank you so much for having me. It's nice to virtually meet all of you. Excited to join. Yeah, I wrote in my bio my interests outside of medicine. So those are the 2 main ones. My 4-month-old is keeping me very busy right now. But I also, aside from running and the baby, have a couple pets to go along with Molly's theme. So we have a Maine Coon cat. And if anyone's familiar with those, they're huge. So he's bigger than our baby right now, which is kind of funny. And then we live in a pretty urban suburb of Boston, but we got some backyard chickens just to have some fun and get some eggs. So that's been a strange new adventure, but it's fun. And then why pulmonary and critical care? A lot of what Molly said resonates with me as well. I think one thing I really like about the ICU is that there is some data to guide your decisions, but then a lot of times you really have to use your knowledge of physiology to decide what's best for the patient, which I think is really interesting, the intersection of the data and then just thinking through how our knowledge of how the human body works. And then I also really like guiding not just patients, but also their families through difficult decisions and difficult times, what, you know, not just end of life, but really anyone who's in the ICU, it's a stressful time. So I find it really meaningful to be able to guide patients and their families through that experience, because sometimes it's some of the most challenging things they've been through. And then kind of as a surprise in fellowship, I actually have been enjoying the pulmonary side of things more than I anticipated. I think it's really interesting. There's more than just COPD and asthma. I think there's a lot that's fascinating there to work through as well. So it's a good career choice if anyone out there is still kind of figuring out what to do.
Oh, thank you so much. That's very inspiring. And today we also have those amazing members from CP Solvers helping us. So Deborah, she will be scribing. Can you please introduce yourself?
Hi, I'm Deborah. I'm a medical student here in Argentina, and I'm happy to scribe today. I love pulmonary and critical care, and now outside of medicine, the World Cup is taking my time. I love watching the games and be crazy about and yeah, that's it. I'm excited for today.
Oh, thank you so much, Deborah. Yeah, I know the feeling. I was just watching the game. We had a great game today for Brazil. So Amanda, she'll be doing teaching points.
Hi, everyone. I am Amanda. I am from Brazil, too. I am a fifth-year medical student. So PCCM, it's an enigma for me, but I really love. And I'm so excited for today and learn from you.
Thank you so much, Amanda. So I think we are ready to start. Dr. Trainor, the mic is yours, and we are going to start sharing the screen too.
All right, sounds good. Thank you. All right, so we're gonna go through a case today of a gentleman who, let me just make sure I can see my screen. So this is a 72-year-old gentleman. He has a past medical history of coronary artery disease and has had a stent placed for this. He also had pancreatic cancer that was just diagnosed 2 weeks prior. So 2 weeks prior to the current admission, he presented because he had some weight loss, jaundice, his LFTs were elevated. So he had a CT scan at that time that showed some common bile duct dilation, some liver lesions, and then also a lesion in the pancreas, which got biopsied, and that's how his pancreatic cancer was diagnosed. So again, that was just 2 weeks ago prior to his current presentation. The other thing I forgot to mention too is during that diagnosis, he also did have an endoscopy where they went to place a biliary stent. And on that endoscopy, they also noted that he had some duodenal angioectasias and an ulcer with a clot, suggesting he had been having some recent bleeding, although he hadn't had any symptoms. So again, so all that was 2 weeks ago, this new diagnosis of pancreatic cancer, but then he represents to the hospital because he's having a lot of abdominal pain, weakness, and some loss of appetite. But the main thing really that he's worried about is his abdominal pain. So I was thinking maybe at that point we could stop and just talk a little bit more about the differential for abdominal pain. So Molly, I don't know if you want to take us through kind of how you think about things, and if anyone else wants to chime in about things that they might be worried about in terms of abdominal pain at this point.
Sure. Yeah, so as an intensivist or critical care provider, when I hear abdominal pain, I'm immediately thinking, is this acute and something I need to urgently respond to, or do I have more time to figure it out? So what I'm going to do is, as I'm getting more history, I'm probably going to be putting my hand on the abdomen. So I want to know, is this an acute abdomen that I need to be calling surgery right away? So signs of an acute abdomen would be, is it rigid? Is the abdomen hard or is it soft? Other things I like to look for are peritoneal signs, and something that I do when I'm interviewing the patient is I'll bump into the stretcher and see if, they really like scream out in pain or if that like bothered them. If they drove into the hospital, I might ask, like, how did you feel driving in? Did it like hurt when you were going over bumps and stuff like that? The other thing I like to do in my mind is divide the abdomen up into a square and think about like anatomically where everything is located. And I'm going to be getting more history and asking very specifically, where is the pain? Where does it radiate to? Because that's going to help me think about anatomically and pathophysiologically what's going on. And then also some of the quality of the pain. So I don't know, Ali, if you have some of those answers, where specifically is the abdominal pain? Does it radiate? And what's the quality of it?
Yeah, it's a good question. So his abdominal pain was more so in the right upper quadrant. He didn't have any rebound or guarding. The pain wasn't radiating anywhere. And it was more of just kind of a dull aching pain that had been going on throughout the day that he ended up presenting.
Great, so that might help me localize a little bit. So if it's more like right upper quadrant is what you said, I think, then I'm thinking like, okay, things that are in the right upper quadrant, I'm thinking liver, I'm thinking the biliary tree, I'm thinking maybe some pancreatitis. We know that he has this new diagnosis. I'm also, wondering, is there anything in the epigastric area, thinking about this duodenal finding that he recently had. But this is kind of helping me to rule out other things like that might be on the left side and really focusing more on my probably biliary tree, liver, pancreas, and then thinking about with his history of the duodenitis and ulcers, thinking about that. Although pain for the pancreas and duodenum are usually more middle and epigastric. So keeping that in mind.
Yeah, it looks like someone in the chat commented maybe a question of gastric cancer, splenic vein thrombosis or ischemia, mesenteric ischemia, and pancreatitis, which I think are also great thoughts. I don't know if anybody else has any other thoughts on, what could be going on here. Pretty vague description, but we have that framework that Molly just brought us through if that brings up any other ideas for anyone. All right, so maybe while we're thinking through that, I can bring you through a little bit more of his history. So I mentioned a little bit of his past medical history. The only things to add there, he also has hypertension, hyperlipidemia, and an enlarged prostate. For his social history, he's a retired auto mechanic shop owner, lives at home with his daughter and also his son, who he takes care of because his son has cerebral palsy. He also smoked 1 pack of cigarettes per day for several decades, but is not actively smoking. And he does not have a history of alcohol or drug use. For family history, his father died of heart disease, his mother died of renal failure, and there is no known history of malignancy. His current medications, also, if I'm talking too fast prescribing, let me know. I'm impressed at how quickly you're getting things down though. So for medications right now, he's taking aspirin, tamsulosin, metoprolol, sucralfate, clopidogrel, and pantoprazole. And then for his physical, and then he has no known drug allergies. And then for his physical exam, won't go through every single thing, but just a few notable things to point out. His vital signs, his temperature is 98. His blood pressure is 99/59. His heart rate is 89. Respiratory rate is 18. And he has a saturation of 93% on room air. And so generally he looks okay. He's, lying in the bed, but he looks comfortable, no distress. His cardiac and pulmonary exams are unremarkable. And then like we mentioned with the abdominal exam, it's soft, but he does have some mild right upper quadrant tenderness to palpation. Not distended, he has normal bowel sounds, and nothing on visual inspection either. So maybe I'll stop there before we get into labs, and see if anybody has any other thoughts about what we think of this gentleman, if this changes your differential at all, or yeah, I guess we can start there. If this would change your differential at all, if there's anything else you would add.
And Ali, did he have any rebound tenderness?
He did not have any rebound tenderness. Good question.
That's something I like to look for when someone presents with abdominal pain, because that's another one of those signs that's making me think more about peritonitis or inflammation of the peritoneum. So pain when you let go more than when you push in. And then I'm assuming no other peritoneal signs either. So I guess what strikes me a little bit on this exam is the relatively benign, I would say, just the mild right upper quadrant tenderness. I am a little worried about his blood pressure, so I'd love to know what his baseline blood pressures are, but what strikes me right here is that 99/59 is pretty low. I'm worried a little bit about his heart rate. I note that he's on metoprolol though, so I'm wondering is his heart rate supposed to be faster with that low blood pressure, and the metoprolol is masking it? And then also the 93% on Romer is a little bit concerning as well, and I want to know if he has any shortness of breath or any pulmonary symptoms at all.
Yeah, so no shortness of breath or pulmonary symptoms. You raise a good point about the heart rate and the blood pressure. So he at baseline does have high blood pressure. So this is definitely low for him. And you raise another good point. As far as we know, he did take all of his medications today. So he does have the beta blocker on board. But especially, you know, being an intensivist, and one of the criteria for thinking of someone going to the ICU is, you know, is this low blood pressure trending in the shock territory? How would you think about his vital signs in this scenario?
Yeah, so there's something that I like to use called the shock index. I'm not sure if people are familiar with that or not, but it's a nice way to basically get a quick sense of, you know, could this person have occult shock? And the shock index is best studied in hemorrhagic shock, but you can use it in other forms of shock to give you like a little sense of what's going on. And it's a nice ratio. It's your heart rate divided by your systolic blood pressure. And, you know, people say 0.5 to 0.7 is like normal, no shock, and above 0.7 gives you a sense that maybe there is some shock going on. What I'm specifically worried about is we know that this person had a procedure 2 weeks ago, so probably less likely to be bleeding from a procedure, but clearly they have risk factors for bleeding with clots, with ulcers in their GI tract, and had evidence of recent bleeding just a few weeks ago. So I'm wondering, like, is there some GI bleed going on? And if you calculate his shock index, it's actually 0.9, so not normal and concerning for potentially having some occult shock.
All right. That was great. Any other thoughts from anyone before we move on? Oh, great. Let's see. So it's hard not to anchor, but it's looking more like a malignant process. That's a great point, Joy. I think we know he has this new pancreatic cancer, and I think it could, you know, you wonder, is this all just the pancreatic cancer and he's having belly pain from that, or is there something else going on? And then Yasmin asked, could the pancreatic cancer cause vascular issues due to invasion? I think that's a great thought as well. You know, is he having bleeding from that aspect? And then Joy commented as well that he is looking, you know, quote, shocky. So I agree. With that blood pressure and that heart rate, we should be a little bit more worried about this gentleman. All right, so kind of moving through, I'll give you a little bit more information. So labs that we have for him, his chemistry panel, I'll say, is completely normal. So I can give you that data, but it's completely unremarkable. His CBC, he has a white blood cell count of 5. His hemoglobin is 11.2. His hematocrit is 32.9, and the platelets are 259. And then in terms of his, sorry, I guess when I talked about chemistries, I wasn't including LFTs in that. Those are not normal. So his AST is 77. His ALT is 80. Alk-Phos is 199. Total bilirubin is 1.2. Has an LDH of 174. And then for coags, his INR is a little bit elevated at 1.3. And his PTT is normal at 33.2. We don't have any new imaging at this point, but just as a reminder, he did have that CT of his abdomen and pelvis that was done 2 weeks ago. And that showed the pancreatic lesion, which was biopsied and showed the pancreatic cancer. And then he also had multiple liver lesions that were shown. And then I see in the chat, somebody said cholangitis on the differential diagnosis too, although it looks less likely with normal labs. Absolutely. He just had a biliary stent placed 2 weeks ago. I think cholangitis should definitely be on our differential. I know you said take it back with the normal LFTs, but it could, it could still be early. Who knows? I think it's still a good thought.
Yeah, I agree. I would definitely keep cholangitis in the differential. He doesn't have a fever, so maybe that's bumping it down a little bit, but totally agree it should be in the differential. Guess what strikes me a lot about the labs and how sort of I'm thinking about this, especially looking at the shock index, which just as a reminder is your heart rate over your systolic blood pressure, is that the hemoglobin, is that a baseline for him? It's a little low for a normal healthy male. Of course, we all know that everyone has kind of their own baseline labs here, but I'm wondering if that's lower than his normal hemoglobin, and am I going down this, is he bleeding route given his shock index of 0.9 and a low hemoglobin? So I don't know if you have a baseline hemoglobin on him or not, Ali.
Yeah, I will say, so we don't have the baseline hemoglobin, unfortunately, but I will say that to kind of bring this case forward, shortly after this gentleman is admitted, he ends up, a couple things happen, which kind of help us to try and figure out what's going on with this guy. So he actually has kind of your broad initial workup that everyone was getting at this time. He got a COVID swab and his COVID comes back positive. He actually does start developing an oxygen requirement. So that 93% sat, again, that is lower than we would expect for someone who has completely normal, healthy lungs. So that does start to trend down. So he gets started on steroids, and his outpatient oncologist is involved in the care, and they're like, you know what, he's going to be stuck in the hospital for a little while anyway. Why don't we use this opportunity to biopsy those liver lesions that we saw in the CT of the abdomen and pelvis? And this is perfect timing. I see Yasmin just put in the chat. There's multiple liver lesions. Sounds like they could be mets from the pancreas. And that's what we're thinking, but we don't know at this point. So the team recommends that he gets a liver biopsy. So he goes for this liver biopsy. And then 12 hours after the liver biopsy, he's feeling really unwell, goes to use the commode and has a large volume of melena, and his blood pressure takes quite a dip and he's feeling lightheaded and dizzy, and a rapid response is called. So I want to stop there and open it up to Molly, or again, really anyone else, to ask, what are we thinking now? He came in with abdominal pain. Then he had COVID, which is kind of confusing, true and unrelated, or was this why he was feeling so unwell? He gets a liver biopsy and now he's bleeding. Is the bleeding related? Like, how do we put all this together? What do we think is going on here?
Yeah, I can comment. I didn't know if anyone else wanted to share some thoughts first.
Joy, great question.
Yeah, so Joy, that I think is what you have to think about first is, is this a complication from the biopsy, or is this coincidental? Because we know that he has risk factors for bleeding, i.e. the ulcers that he has. And thinking about, where is this bleeding? If it's melena, it sounds like it's in the GI tract. And I don't know, Ali, if you want to tell us a little bit more about melena.
Yeah, it's a great point, because we know that he had those duodenal ulcers that were seen on an endoscopy 2 weeks ago that had stigmata of recent bleeding. And melena can actually really stay in your GI tract for about 5 days. So this melena is really tough to interpret in this setting, where we know that he had probably a GI bleed earlier based on what the endoscopy showed. So we don't know if he's having melena at this moment because he's having an active GI bleed going on right now, or did he have a GI bleed several days ago and then it's just still clearing through his GI tract, and maybe there's another reason why he's feeling unwell and his blood pressure is dipping. So it's a little bit tough to tell. I'm curious, what do people think about the steroids in this case? Do we think that could potentially be related? If we're trying to figure out, is he bleeding now or was this old? And I will say, in the meantime, I'll just cut to the chase and tell you he is bleeding now, even though it's a little bit tough to tell in the moment. Of course, the team sends off a CBC, and his hemoglobin initially was 11.2, and it comes back at about 6.5. So he's bleeding. and he's lost quite a bit for that significant hemoglobin drop. So once the dust is settled, you're kind of thinking, could the steroids have contributed? Should he have been started on the steroids for COVID when we knew that he had ulcers? What do we think? Yes, Yasmin says, don't steroids increase the risk of GI bleeding? Yes. And Swathi asks, was he on a PPI before? So the PPI was only started after that endoscopy that he had 2 weeks ago when they saw the ulcers. So what do you guys know about steroids and risk of GI bleeding? Is it real? Is it overblown? Should they have maybe held off on steroids because of the ulcer they had before? What do you think?
Deborah wrote, it's a good question.
Yeah.
So I think maybe Ali, you could tell us a little bit about the risk, but I would say, you know,
Yeah.
in this setting, if he does have COVID and if he is hypoxic, and given his age, I probably would have started him on steroids, but cautiously, knowing that history that he has. But I think it's probably risk benefit, but maybe you can share some of the data with us.
Yeah, totally. I think it's tough because we know that in hospitalized patients who have COVID and who are on oxygen, that there's an improvement in outcomes when we start them on steroids. So I wanted to look back and see, you know, what is the risk of GI bleeding when we start someone on steroids? And I found really 2 meta-analyses that I can share with you that were interesting. So one was looking at the effect of systemic corticosteroids, and I can put the links to these articles in the chat for you guys. Let me see how I can do that. So the first one was looking just at steroids in patients who are critically ill. And the second one was looking at corticosteroids and risk of GI bleeding in both hospitalized patients and outpatients. So it seems like in outpatients, there's really not much of an increased risk in this meta-analysis. Interestingly, also in critically ill patients in the meta-analysis, they didn't find a significant increase in GI bleeding risk. However, in hospitalized patients in that second meta-analysis that I shared with you guys, there was a significant increase in GI bleeding while on steroids. So it's also, I think, tough to say which group does this patient fall into. Even when you're looking at an RCT, it's tough to say, does my patient fit in the patient population that was studied? It's even more difficult when you're talking about a meta-analysis. So I think you can use that information, but it can get a little messy. So it's hard to say, did he fit in the critically ill population, or did he fit in the hospitalized population? Because we talked about he was a little shocky already to start. So I think my takeaway would be he probably is in the category of people where this probably did increase his risk of bleeding, particularly since we know that he had duodenal ulcers before. However, I do still think, and maybe I'm biased because of how many really sick COVID patients we saw a couple years back, I do think it was the right decision to start him on steroids because you can manage a GI bleed, but a lot of these COVID patients who got really sick with ARDS, it's really hard to stop that if we're, you know, not using these steroids up front. So I think it was the right choice, but definitely a risk benefit decision that you should be thinking of when you're starting your patients on steroids, particularly if you know that they already have ulcers that have shown recent bleeding. And then I realized there were a couple of things that came up in the chat while I was going on and on about steroids. Great question from Anne Marie. Was he on DVT prophylaxis as well, or maybe full dose enoxaparin, considering the data in medium risk hospitalized patients? That is a fantastic question. This patient was put on DVT prophylaxis. From what I remember, the reason being they did know about the ulcers, but they were also worried because he had a malignancy. So they felt compelled to do DVT prophylaxis. But you're right that that's an important consideration that should be thought of as well. And then we have another question about, was he on PPIs for prophylaxis before the steroid? He was. So those were started 2 weeks ago when he had the endoscopy. So potentially could decrease some of that risk, but I think the risk is still there. Great questions. Other comments or questions on that point before we keep on going? Okay, so maybe what we can talk about next is I'll say, maybe you can talk about steroids and COVID, please. Yeah, sure. That's a great question. So I think we can do a little aside. I don't have the numbers off the top of my head. So Molly, if you remember, feel free to chime in. But essentially what we know about steroids and COVID is for outpatients, starting steroids for patients who are COVID positive in the outpatient setting, we actually saw worse outcomes. Whereas patients who were hospitalized and on oxygen or in the intensive care unit, when we started steroids in those patients, we actually saw an improvement in outcomes. The theory behind why is that the thought is that a lot of the disease in the outpatient setting is more from your viral load is kind of ramped up. So if we give you steroids and you have a higher viral load and we kind of tamp down your immune system, then the virus can just kind of replicate more out of control. Whereas potentially, and again, this is all just theory as to how we and why we saw this outcome, that when you're in hospitalized patients who are on oxygen and in the intensive care unit, the viral load is already kind of starting to go down, but what's happening is the inflammatory response is totally out of control. And that's what's leading to damage in your lungs. So the thought is in those patients, giving steroids will tamp down the inflammatory response, and that might be why you improve outcomes. Molly, I don't know what you would add to that.
No, I think that's right. I was just, there's a couple different trials. I was trying to get the links into the chat, the recovery trial, the Codex trial. We can put these in the chat for you. But yeah, I think we've learned that steroids are helpful in the inpatient population, and my practice is to be using them for patients who require oxygen. And I had mentioned earlier that this patient was higher risk given his age and his other comorbidities. So I'm even thinking more about, yes, he needs to get on some steroids before he gets sick from his COVID. I think the challenge in this day and age now, and that we're probably going to face for the rest of our lives is, is COVID just sort of a bystander and we just diagnosed it because he came into the hospital and we're swabbing everyone, or is it contributing to this case? And that also helps us think a little bit about, should we treat it, should we not treat it? But it can be really challenging up front. And just like you said, Ali, we need to treat COVID and with patients, in patients who have oxygen requirements so that they doesn't lead to more complications. But something to constantly think about in this day and age is COVID really causing a problem, or are we just finding out that this person is positive because we swabbed them?
All right, great discussion. I know we weren't anticipating that one, but Molly and I both took care of too many COVID patients to count the past few years. So happy to chat about questions on that front. So maybe to get back to what's going on with this patient. So we talked, oh yeah, no problem. So we talked about he is now rapid response is called, he has melena, his hemoglobin has dropped. So we're fairly certain that this patient is in hemorrhagic shock. In the background, we might have some ideas about where this is coming from, which we can talk about, but specifically want to ask Molly about kind of your approach to managing these patients acutely. So we can talk about how to figure out where he's bleeding from and how to stop it, but what do we do in this immediate setting when this patient is bleeding and decompensating in front of us?
Yeah, thanks. This is my bread and butter, Ali. I just wanted to respond to Yasmin. It's a great question that the patient was on a PPI and on sucralfate and maybe still having these ulcers. Can we say that they're not responsive to treatment and thinking about a gastronoma? Definitely a good thing to keep in the back of your mind. I think probably too soon to say in this case, because it was just 2 weeks ago that this patient was diagnosed with these ulcers and started on the PPI and the sucralfate. So hard to say that this is a failure of treatment right yet, but definitely something to keep in our minds for sure. So based on what's happening, I would say that this person needs to immediately come to the ICU. And when I see someone who I think is in hemorrhagic shock, so again, I'm going to calculate that shock index. So we knew that it was 0.9 before, so your heart rate divided by your systolic blood pressure. And you told us that his pressure tanked, and I'm wondering, was he tachycardic also?
Yes, sorry, I mentioned only the blood pressure, but his heart rate's up into the 120s at this point too.
Okay. So if we calculated his shock index at this point, it's probably over 1, and we can share some of the papers about the shock index too, but some retrospective studies have shown that in hemorrhagic shock, the higher your shock index, the more blood products you needed. There's also a retrospective study showing higher shock index correlates with mortality. So this is the nice thing that I like to use. People may have seen tables in textbooks of class 1 shock, class 2, class 3. This is sort of the quick and dirty version of those classes of hemorrhagic shock. So what I'm thinking about is, how am I going to stabilize this patient? So I'm going to get them to the ICU so that they can be in a more controlled setting, because this person is on the floor right now. And then one of the biggest things that I'm thinking about is getting them blood products. So I know they're bleeding, their hemoglobin dropped, we're seeing melena. I want to be giving them products like ASAP. So I'm going to think about, how should I give them products? Hopefully I have a type in screen already from the blood bank, so I know what blood they need and I can order that and get it up quickly. Or do they need more quick products than something called a massive transfusion protocol, which is a protocol that we have at our hospital. There are different ones at different hospitals, but that will give you a cooler of blood products right away, so that you can get blood emergently into these patients. I think before we even think about the blood, though, I'm wondering, does this person even have access to get blood? So do they have peripheral IVs, or what's sort of their access, Ali?
Yeah, so this guy, of course, unfortunately at this point has one teeny tiny 22 gauge peripheral in his hand. So we're in a bit of a bind.
Okay, so that is something I would say I think a good learning point for all is that when you are seeing someone who is in hemorrhagic shock, make note of the size of their IVs. That should be part of your physical exam. What's the color of the IV and what size is it? So 22 gauge is really small. So when we think about, and I see Joy, yeah, 2 large bore peripheral IVs, that rolls off the tip of our tongue when we think about a bleeder. So large bore, what does that mean to people? Not a 22 gauge. So 18 gauge or bigger. Yeah, 16 or 18. Love that, Swati. Thank you. Absolutely. So we want these large bore IVs. And the reason for that is because we know the larger the IV, the faster the blood is going to go in. And this is related to Poiseuille's law. People probably have better French than I can and can pronounce that more beautifully. But this is an equation showing us that the flow of something through a tube is equal to pi times the pressure times the radius to the 4th, divided by 8 times your viscosity and your length. So what that tells us is that the flow is going to be directly proportional to the diameter, so to the radius to the 4th, or the size of the IV. So the bigger the IV, the faster the flow. Also, pressure is in that equation, so that's why we think about pressure bags. And if we don't have a pressure bag, we can squeeze the blood bag so that it goes in quickly. So think about that. Think about the size of your IV, the diameter, and think about pressure. The other thing is that it's inversely proportional. The flow is going to be inversely proportional to the length. So the longer your IV, the slower the flow. So short and fat IVs are great for GI bleed to help us get fluid in quickly. So we often think, oh, should we put a central line in this patient? But central lines are long IVs and the gauges aren't that big. They're 16 and 18 gauge. So it's important to think about using a Cordis or a trauma line or a MAC line. There are different names for these lines, but these central lines that are short and fat, that they're not as long as triple lumen catheters. They're shorter than that, and the diameter is bigger. Other things to think about are your good peripheral IVs. A 16 gauge IV will get blood in very, very quickly. Actually can go in about 200 cc per minute in a 16 gauge IV. And you can also think about IOs, or intraosseous access, in these cases. And depending on where your IO is in the tibia or in the humerus, blood can flow in up to 100 to 200 cc's per minute too. So they're good lines as well, not as good as a Cordis, which would be the best line to use in this case. So that's what I'm thinking. I need to get access, and it needs to be good access and I need to be thinking about blood products. And I think I saw someone in the chat ask about massive transfusion. Yeah, so the massive transfusion protocol doesn't just give you packed red blood cells. It will give you FFP and platelets as well. And there are different ratios. When we think about this, a lot of people think about using a 1-to-1-to-1 ratio. So a unit of packed red cells, a unit of FFP, and platelets. The reason for this is that if we just give packed red blood cells, we're going to dilute out clotting factors, and we're going to cause more harm. This person's not going to clot. So depending on your hospital's massive transfusion protocol, it may be a little bit different. A lot of times protocols are 4-to-2-to-1, so 4 units of PRBCs, 2 FFP, and 1 platelet. And then after 4 or 5 coolers, many protocols also include giving some cryoprecipitate then as well. I think the exact ratio is a little bit less important than just making sure you're giving more than just blood. You have to give these FFP and you have to give platelets as well. Would you add anything else to that, Ali?
Yeah, so the only other thing I'm curious your practice on, that we didn't talk about this before, but when do you usually start thinking about checking calcium or giving calcium in these patients?
Yeah, it's a great question. So important to give calcium because the blood has citrate that will bind up the calcium, so people become hypocalcemic. So I usually just give it after my 3rd unit of PRBCs, and some people say like 3 to 4. My practice is like for every 3rd, I'm giving some more, and then I will check it like as I'm continuing the massive transfusion, but I don't check it before I give it. So if I'm giving 3 units or 4 units really quickly, I'm going to give them some calcium as well. And then that is something that I'm going to follow.
Awesome. Thank you. All right. That was great. So moving through the final parts of the case here. So this man is transferred to the ICU. The massive transfusion protocol is started, but he actually, during this process, has a PEA arrest as well. ROSC is able to be obtained. He gets adequate access. Sorry, ROSC, return of spontaneous circulation. I don't know if we all use the same abbreviation terminology. So they get a pulse back, continue the massive transfusion protocol. And then at this point, they're deciding, how do we stop the bleeding? So what do you all think? Who would you reach out to for help, or what would you do for this gentleman at this point? Feel free to put some answers in the chat. Where do we think this is coming from, and how can we stop it? Angioembolization, great. Throw back to me, great. Page surgery, yes. Yeah, all great thoughts here. Essentially, I think what you're all reaching out to is, we are medicine doctors and we have great brains, but we need help. I know some of you are med students, so you haven't decided yet, but Molly and I, we've done the things we can do. We got to call for help. So Molly, who would you call for help, and how would you organize this?
Yeah, it's a great question. So in a patient with hemorrhagic shock who has now arrested from their hemorrhagic shock, I'm actually probably going to call sort of the 3 people that I think can help me and really chat with them all at the same time. And in fact, we're trying to put together a protocol here at our hospital where we get all the right people on the phone. So I'm thinking about GI. That is, do they need to do an endoscopy? Because I'm worried still about this luminal bleeding from these ulcers. I'm getting surgery involved right away, and I saw that in the chat, absolutely. And then I'm getting IR involved right away. So what I'm going to try to do is get all 3 of these people involved and sort of present the case at once, and then make a decision all together of what is the next best step, what should we do? And honestly, given how sick this person is, probably the fastest would be to try to go the IR route, I would say, because it's going to take a while for an endoscopy. And if someone's having this much bleeding, it's hard for GI to even see when they put the scope in. So I would probably I would consult all 3, but I would probably favor going the IR route first, but having surgery on sort of backup and standby, because if we can't solve this via like an embolization, then we may need to go to surgery.
Yeah, so that is actually exactly what ended up happening in this case. So called GI, IR, and surgery. And GI said, we're here for you, but we won't be able to see anything. It's just too brisk. So IR took him down for a procedure. And what they told us that was actually an interesting teaching point for me is that if a patient is kind of semi-stable, it's preferable to first send them for a CTA to localize the bleeding, because that actually uses less contrast. But if because, with the CTA test is like kind of a bolus of contrast that visualizes all the vasculature, whereas if they're kind of blindly shooting dye at their best guesses, they actually have to use a lot more dye. So they try to go the CTA route first if they can, but if the patient's just extremely unstable and they have a good guess as to where it's coming from, they'll just take them straight for embolization. So in this patient, given that we knew that he had some duodenal ulcers that were seen previously, they just took him straight for embolization. And they did a gastroduodenal artery embolization and actually were able to stop the bleeding and return him back to the ICU. So that is actually all we have for the case. I loved all the participation you guys had. We're also still here if people have any other questions or thoughts that they have on any aspect of the case that we can clarify for you guys or that you want to discuss further.
Ali, one thing I might add is when we, as intensivists, when we are sending these patients for these procedures, we can also feel like, oh, maybe I'm a little powerless because I can't fix this, but you actually have a really important role as the intensivist or the internal medicine doctor by securing access, making sure you're giving them the appropriate products, and then really making sure that you're managing the complications of all of these products, which is something that we often don't think about, but especially if we're doing massive transfusion. The calcium we already touched on, so hypocalcemia is real and can cause bad side effects. So important to be making sure that you're giving calcium and that you're managing hypocalcemia. Other things that can come from massive transfusion are hypothermia. So that's a reason that we use blood warmers, but a really important thing to keep in mind. And then hypervolemia. So, we know that this person has coronary artery disease. I don't know what his EF is, but important to make sure that, of course, we're going to be giving all these products right up front, but we may need to be thinking about diuresing these products off later. Another thing that I'll just point out that's an important point to think about in critical care is something that's called the trauma triad of death, which sounds very ominous, and it is. But in these hemorrhagic shock patients, it's really important to keep these three things in mind. So the trauma triad of death is coagulopathy, and we are giving these patients a coagulopathy oftentimes with all the blood that we're giving them, and they may already have one. That's one part of the triad. The other part is acidosis. So they are, hypotensive, so they're going to have an elevated lactate. So that's problematic. So acidosis is the second part of the triad. And then hypothermia is the third part of the triad. And I mentioned that already. It's important to make sure that we're using blood warmers and that we're keeping patients warm. And the problem with this triad is that each one of it is like a triangle. It leads to the other. So coagulopathy can lead to acidosis, can lead to hypothermia, can lead to more coagulopathy. So it's just sort of this vicious cycle that you as the intensivist need to make sure that you're breaking the cycle. So you're giving them FFP, you're giving platelets, you might need to give other products to help with coagulopathy. For the acidosis, you're thinking about, do they need early dialysis? Are they on mechanical ventilation, and can I tweak the ventilator so that I can improve some of the acidosis? And then we talked already about the hypothermia. So using blood warmers, putting a bear hugger on them, making sure that they're warm. So don't just stand there and say, now they're in IR, I'm done, I don't need to take care of this, but you need to be monitoring labs and you need to be fixing the things that you as the intensivist can fix. Because if you don't, it's just going to lead to more harm.
That was great. Molly, I think based off of what you were just bringing up, Swati asked a good question in the chart of how fast can you run the blood products if this patient had heart failure, which I think is such a tough balance. So I don't know if you have any tips.
Yeah, that's a great question. Well, this is one of the reasons that I think pulmonary critical care is the best, because shock trumps everything else. So if this patient's truly in hemorrhagic shock, you need to get the products into them quickly, or else this patient can arrest, like happened in this patient. So what I would say is if they're in hemorrhagic shock, you shouldn't worry about what their EF is. You should just be getting the product in really, really fast. In these patients, they probably should be intubated early, because the biggest issue if someone has heart failure is that they're not going to tolerate that volume, right? And they're maybe going to need to be intubated. So I would just go ahead and intubate these patients right away, and then you don't really have to worry about it. But what you should be prepared for is in the next 24 hours or 48 hours, you're going to have to probably deal with all this volume, because their bodies are not going to be able to deal with it. Whether you need to do some renal replacement therapy to take the fluid off, or you need to be aggressive with LASIK. So I would say in the hemorrhagic shock patient, treat the shock, worry about the heart failure later. In sort of a floor patient who has a little bit of a bleed and a low EF, you probably are going to run it a little bit more slowly, but you have the luxury of time to do that. In this case, unfortunately, you don't. You just have to fix the primary problem and then deal with the consequences of it. But thinking about intubating early if they're not going to handle the volume load is really important. I don't know how you would approach that, Ali.
Yeah, I was curious your thoughts, because I've run across this scenario, I would say not too often yet, where I've had a patient with such severe heart failure with reduced ejection fraction that I was really worried. I mean, I've had kind of like borderline 35% maybe, but we just gave all the product. Justin asked in the chat, do we know why he got the duodenal ulcers? Great question, because if we had addressed that or knew why, then obviously we could avoid these, catastrophic outcomes. Unfortunately, we don't actually know more about the ulcers. We kind of stopped the case there for the sake of time, but unfortunately, what ended up happening to this gentleman was about 12 hours after that procedure, he did end up rebleeding, his blood pressure dropped, and he did end up passing away. So we unfortunately don't know more about the duodenal ulcers in this case. Other questions or comments anyone has?
Oh, thank you so much, Dr. Trainor, Dr. Ray, for being here and for this amazing discussion in this case. Unfortunately, it is very sad outcome, but I feel that we were able to learn so much in the discussion today. I especially love the approach of his rapid response and you walking us through what happened and what we should do. And I think, does anyone have any other question? Just wait a few seconds. Okay, so just for us to finish, I'd love to hear from you both, your final reflections on the case, now looking back, and if you could choose one main teaching points for us to take home today, what would it be?
Yeah, I think the one take-home point for me is just not underestimating hemorrhagic shock and kind of acting fast. So when you see someone who's really bleeding or heart rate's going up, you need to act fast to get ahead of things. And I think a teaching point that, I hope I'm not stealing Molly's, but that's also why I jumped in before you. She made this teaching point, but I really love the shock index, because I think it can give you a great idea of how sick a patient is when otherwise, again, his initial vitals, you might look and say they're borderline, but when you actually calculate the shock index, it raises your suspicion a little bit more that maybe there's something really going on with this guy that I should be worried about.
Yeah, I will say a similar teaching point that I think something that I like to teach my teams when I'm rounding in the ICU is never underestimate GI bleeds. So we see a lot of GI bleeding patients on the floor for triage, and I'm using that shock index in helping triage, because even in this case, you thought there was a bleed, we thought we fixed the bleed, and then he bled again. And this is a very common story for GI bleeding. So even if someone bleeds on the floor and, seems better, like really look at those vitals carefully, look to see if they're on a beta blocker and maybe their heart rate looks normal because it's being beta blocked. So really important things to think of. And then I think my two favorite teaching points are short fat IVs, always, always, always. And I think it rolls off the tip of our tongue that we need 2 large bore IVs, but what does that really mean? So look at your patient, put the their IVs and your physical exam in your note documented so that you know this isn't good enough. And honestly, I think a reflection on this case, if we were worried about bleeding from the beginning, we shouldn't have just left this patient on the floor with a 22 gauge IV. We probably should have given him better access from the beginning so that when he did start opening up and bleeding, we could have resuscitated him a little bit more quickly because that access would have already been taken care of.
Oh, and Joy has one question. Was their heart failure contributed to their outcome?
Good question. So although he had coronary artery disease, he actually didn't have any heart failure. So I don't think that ultimately contributed to what ended up, him ending up arresting. I think his bleeding was just unfortunately too fast.
Thank you. Does anyone have any other question before we finish? Okay, so thank you so much for being here today. I feel that we learned so much, and I love that approach, the importance of the vital signs, the shock index, and I'm sure we are going to take that for life. So we are very, very grateful. And now I handle the mic to Amanda. You can see how much we learned today, her teaching points. She has a big list. So thank you so much, Amanda. The mic is yours.
Thank you for the discussion, Dr. Trainor and Dr. Hayes. I'm so glad to be here, and I learned a lot from you. So my teaching points for today is about abdominal pain. It's important to know about acute and chronic, and I love use the mnemonic Socrates because give us the site, 1 sec, characterized, radiation, associated symptoms, time course, and exacerbation. Check the abdominal pain causes like vascular inflammation, perforation, obstruction, and check if you will need surgery. Localization in the RU key, things in liver, biliary, or RL key, appendicitis, or in the epigastrics, things in pancreatitis, GI bleeding going on, shock. And it's important about pancreatic cancer can cause vascular bleeding and shock. Abdominal pain, thinking the extra cause in the extra abdominal organs like CV plus pulmonary like PA, pneumonia, MI, HF, and COVID-19. And complications from biopsy, risk of bleeding, traumas, and infection. Steroids can contribute with the bleeding. It's necessary for the COVID and can cause bleeding, COVID and hypoxemia, and steroids, the patient improve with steroids. And steroids increase the risk of GI bleeding. About the hemorrhagic shock, where is the bleeding coming from? Start IV fluids and transfusion if necessary, massive transfusion, 3 main production, plasma, platelets, and red blood cells, can cause hypocalcemia and give calcium after 3 units, and other side effects, hypothermia, check the temperature, hypovolemia, and acidosis, consider dialysis, and page GI surgery and ER if necessary. Thank you all for the discussion, and have a nice rest of the day.
Thank you. Bye, everyone.